Welcome to ANA Investigates, a monthly podcast covering the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. This month, we'll have part one of a two-part episode on unbiased diagnostics in neurologic disease. In this episode, UCSF's Richie sat down with UCSF's Michael Wilson, a neuro-immunologist specializing in infectious diseases of the central nervous system. They spoke about the unbiased technique called metagenomic next-generation sequencing, or mNGS, a technique developed through the UCSF Center for Next-Gen Precision Diagnostics. Hi, Megan. Thanks for joining us.
Thanks so much for having me.
So you spoke to Dr. Wilson about the technique called metagenomic next-generation sequencing, or mNGS. What is mNGS?
So metagenomic next-generation sequencing is really best understood when you compare it to the traditional candidate-based model for diagnosis of infections. And so what I mean by that is most of the time when you want to diagnose an infection of the nervous system, you need to send specific tests based upon each item on your differential diagnosis. And so your list of diagnostics is naturally limited based upon your own amount of time, your knowledge, your resources. But Michael's going to do a much better job of explaining this for us. So let me play a recording to you of something that he said during our interview.
Metagenomic sequencing is a different approach in which all the RNA and DNA from a biological sample, in our case spinal fluid, is extracted. And then instead of going in with targeted probes like we do with a herpes simplex PCR, we go in with millions of random primers that are able to amplify all the nucleic acid in an unbiased way for deep sequencing. And so we sequence all the material in the sample, and then after a series of computational steps where you subtract out all the human sequences, which make up the vast majority of the sample because it is a human sample, and we filter out redundant sequences, low quality sequences, you're left with a kind of a nugget of small number, usually a few hundred or few thousand sequences that are not human or high quality, not redundant. And those sequences are then searched against large publicly available databases to figure out the identity of the organisms from which they came.
So it's like looking for everything that shouldn't be there in the CSF, amplifying it, and then cross-referencing against a library.
Exactly. I want to talk to you about one clinical advantage that's immediately obvious thinking about this method. Here's Michael.
In that way, you can be surprised. So you can find infections that you maybe weren't on your differential, either because it's such a rare infection it hadn't been considered, or because it's an infection that's not usually associated with the patient's particular phenotype, any number of reasons. But that's basically how the technique works.
Does that make sense?
Yeah, it totally makes sense. So how would you use this?
Yeah, so let me talk to you about an example that Michael gave me because it really helped me understand how it gets used clinically.
One case that surprised us in a paper we recently published was a patient who we found had a hepatitis E virus meningoencephalitis. This was a woman who had a history of MS and also had a bilateral lung transplant for pulmonary fibrosis about 6 years prior. And since her transplant, she had become labeled as a frequent migraineur and presented to the hospital frequently for headaches and pain control. And when we heard about her, she had recently been discharged from the hospital for another headache episode, but then she came back again with severe headaches and a fever. And so this prompted a spinal tap where she was found to have a lymphocytic pleocytosis. And she was enrolled in the sequencing study and was found to have large numbers of sequences that matched to hepatitis E.
So I thought this was a really interesting example because here we have an immunocompromised patient who could really have any number of hundreds, if not thousands, of infections. And the fact that the mNGS was able to look at all the nucleic acids in her cerebrospinal fluid and pick up this infection that honestly I probably never would have sent independently was amazing to me. But guess what? The story gets even better.
But the plot thickened in her case. So it also turned out that since her lung transplant 6 years prior, she had had a spike in her transaminases and was developing cirrhosis and was on her way to being listed for a liver transplant as well. And of course, she'd had extensive investigations for what was going on with her liver, and it had ultimately been called non-alcoholic steatohepatitis. And but then once the hepatitis E was identified in her spinal fluid, it was realized that that was also the likely cause of her impending liver failure.
So how did it turn out?
So the story has a really fantastic ending.
We were able to get serum from the lung transplant donor and found that that the lung transplant donor actually had a Hep E infection that had been unrecognized. So that really tied the story together, that she had gotten the hepatitis E from the lung transplant, had a progressive liver disease as a result that was unrecognized, and was also having a CNS infection. So thankfully, in her case, she was treated with ribavirin, and not only did that fix the CNS infection, it also normalized her liver function.
Wow. So this sounds really useful. How would I send this on my patients?
Yes, I had the exact same question. So, with some creative effort by the UCSF group, it turns out they were able to actually clinically validate this test. Here, Michael explains.
To clinically validate a test, you have to benchmark it against existing tests, and it's not trivial to come up with a method by which to do that for a test like this that can identify anything. So you can't just compare it to the herpes PCR you used to use.
But in the end, it worked out for the UCSF group.
The test is clinically available now at UCSF, and it can be ordered by both physicians at UCSF, but also as a send-out test from hospitals around the country. And we recently published a paper describing the first year of our experience, in terms of the performance of the assay.
So, Megan, is there anything that I should be aware of as a clinician when I'm sending this test?
Yes, there is a very important caveat to using mNGS that Michael explains here.
People needing to remember that it is a direct detection method. So it's kind of like an enormous PCR. And if the organism is not present in that particular sample, the test is not going to be useful. So in terms of thinking about the implications for a negative test result, it's always really important to keep that in mind. Another pitfall is that it is an unbiased test, and it will pick up all the nucleic acid in a sample, including nucleic acid that was picked up from the skin when the LP needle was passed through the skin, any contaminants that are in the clinical lab, et cetera. So we've published, and other groups have published papers on how to deal with in a rigorous way with mostly bacterial and fungal contaminants that show up in these data sets, and trying to avoid interpreting those bacterial and fungal signals as true infections. And so that's a really critical kind of piece of quality control that any lab that's doing this needs to take into account and be really vigilant about. Another pitfall in this large case series we recently published is, again, to remember that in addition to the timing of the CSF sample being important, also remembering that if someone has a compartmentalized infection, so like a bacterial abscess, that testing CSF may be relatively insensitive compared to testing the abscess fluid, for instance. So just keeping that in mind as well. At UCSF, I think the practice pattern has evolved to freeze down spinal fluid when a patient first comes to the ED with a meningitis or encephalitis, and just to have that initial CSF available if after the first day, 2 days, 3 days of test results come back and they're all negative and the patient is still not doing well, then there can be a decision to send that test off.
So you see, it's really important that the sample that gets sent for mNGS actually contains the organism of question. Therefore, the sample that really makes the most sense to send is something very early in a patient's presentation.
Before, say, antibiotics or other treatments.
Exactly. Here, Michael explains.
The key is to remember that mNGS is a direct detection method. So it's dependent on the RNA or DNA of the organism being present in the sample that's being tested. And so having that initial CSF sample, even if you don't send it right away, just having it available and frozen can be incredibly helpful a week or two later in the patient's course if people want to send that test, because it's much more likely that, let's say, an acute viral infection, that the virus is present in that initial sample than it might be 2 weeks down the line when the patient may still be sick, but the virus may have come and gone.
So how do we make sure that that first CSF that's obtained maybe in the emergency department is frozen down in a way that it can be sent for mNGS later?
So samples need to be frozen at minus 80 degrees Celsius in order to be most effective at preserving the nucleic acid of the organisms. The turnaround time once the sample is sent to UCSF is fairly quick. They do one run a week, and so it might be a few days to a week before results are ready.
So it sounds like it's important for any clinician who's hoping to send this test to just check with their lab and make sure that the way that they're preserving CSF samples early on in a patient's course would allow that CSF to be sent to UCSF later on.
Absolutely. It's certainly best if the samples are frozen. That being said, even a refrigerated sample still could have nucleic acid of value remaining inside, and so sending those samples is still acceptable.
So Megan, how much does this cost?
So mNGS costs about $2,000 and actually I think has the potential to be very cost effective in certain situations, but let Michael explain.
The test itself is approximately $2,000, which, for a patient who turns out to have a simple aseptic meningitis from an enterovirus may not be terribly cost effective. But for a patient like the one I just described who potentially avoided a liver transplant, a $2,000 test that identified a treatable infection is incredibly cost effective.
So it sounds as though the patients in which mNGS are going to be the most helpful are those where there's real diagnostic uncertainty and they're not improving.
So Megan, I know you work at UCSF and that you've used this technology before. What's been your experience?
Well, Adeline, I'd say I've had a range of experiences using this test. In many cases, the metagenomic next-generation sequencing doesn't yield an organism. And there might be a lot of reasons for that. They might not actually have an infection, or sometimes there are simply too many human cells present in the sample because of how inflammatory the spinal fluid is, and that nucleic acid kind of gets in the way of the infection. Sometimes the patients have already been treated with antibiotics, and sometimes we find the diagnosis through a non-direct method of diagnosis, like a serology, that really shows us that the patient has been exposed to an organism even if the organism itself is no longer present in the spinal fluid. I've also had a couple of results come back with a contaminant organism, as you might expect for any direct-based diagnostic method. In those cases, it's really important just to consider the clinical scenario and know the common contaminants to the procedure. That being said, I have definitely had cases where the mNGS has given us a specific organism diagnosis that has really changed the management for patients. For example, even if you know a patient might have a fungal infection from elevated beta-D-glucan in the cerebral spinal fluid, knowing which fungus it is makes a huge difference in order to be able to tailor the appropriate fungal therapy and duration.
Really interesting, Megan. Thank you so much to Dr. Wilson, and thank you, Megan, for sharing what you learned about mNGS. For our listeners, remember, this is a two-part series on unbiased diagnostics in neurologic disease. In our second episode, Megan will talk with UCSF's Dr. Sam Pleasure about an unbiased approach to identification of autoantibodies. Dr. Michael Wilson will return in that episode to compare and contrast between the two techniques.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us. To learn more about today's program and to access more of the incredible content produced by the ANA, check out myana.org. Adeline Goss is our host. Our producers are Romer Giucaden, Adeline Goss, Michael Halstead, Megan Richie, and Jim Sigler. Our editor is Jen Hurley. If you'd like to learn more about receiving CME credit for listening to ANA Investigates, visit myana.org and navigate to ANA Investigates under the Education tab. For more information not covered in today's program, check out the official summary of this episode, published in one of the ANA's journals, the Annals of Neurology or the Annals of Clinical and Translational Neurology. Copyright, the American Neurological Association.